an hour ago and has sustained this displaced type 2 effusive injury of his wrist. Whenever you see this much of displacement and you have got this spike, majority of the patients will have median nerve symptoms, as in our patient he is complaining of loss of sensation and some weakness in moving his fingers. So always look at dinner fork deformity. This is a pediatric equivalent of it, and this is a type 2 effusive injury, which is the commonest. So if at all you see these fractures, usually you will see two types. One, when the fracture is through physis and there is small displacement. On other occasion, like in our case, there is extreme displacement and almost there is no contact between the proximal and the distal fragment. Now, how to reduce this? For these kind of fractures, if you just give a counter traction and traction, usually things will fall back. For these fractures in which there is a fracture to the physis, part of metaphysis, and it's completely off, I would say don't go straight on traction, because here you have periosteum, and sometimes periosteum can be in between, and then it just hinders the reduction. So for reducing these fractures, just give longitudinal traction, palmar flexion, and neutralize the displacement forces, and you will get it. Here you need to exaggerate the deformity, and then once it is slightly reduced, then give traction, and hopefully that will reduce the fracture very well. One thing is that you don't need a lot of forces to reduce this fracture, so don't be harsh and use too much of force, because that way you will cause more harm to the physis. So all you need is to just exaggerate the deformity. I'm exaggerating it and then trying to reduce it. Once you exaggerate it, you can see majority of the deformity is almost corrected. I'm just going to take a check X-ray to see if there is now some contact between the proximal and the distal fragment or not. So now you can see on AP, as soon as you start seeing this physeal line, that means your reduction is good. Even if you don't see the lateral, that will give you an indication that you have done a good job. Now looking at the lateral, again you can see this is nicely reduced, and I just use these two 4 fingers. You don't need a lot of forces, you just need to be gentle. If you use too much force, you will cause more damage to the physis. So you just need gentle manipulation to reduce these fractures. Now you have two options. You can treat this in plaster if it's stable, but if you have screened it, and if it's unstable, then you're better off putting a single K-wire. In developed countries, patients, they keep up their appointment quite regularly, and if you call them at 1 week, 2 weeks to make sure that it has not redisplaced, they will come for the appointment. However, in India, I have realized that not every time patient will follow up your instruction, and hence I am a bit aggressive when I am practicing in India, and I try to secure it with a single K-wire so that I minimize the risk of redisplacement. Now people think K-wiring of a bone is a very straightforward operation, and I agree it is, but it can be very difficult as well. What can you do to make this operation easy? In orthopedics, if you have got 3-dimensional orientation of the bone that you are attending, then you will be able to do this procedure in a very easy way. So this is, I have just drawn on the lateral, this is your epiphysis, physis and metaphysis. I have drawn it on the lateral so that I can align my K-wire here. The first step of passing the K-wire is to check the position of the K-wire first in AP to see whether your entry point is correct, and I take the wire in hand, and then in lateral, and I will show you how it looks. So if you look at the AP, our entry point is pretty good. We can accept it. All we need is to angle it slightly that way, and that should be fine. Now coming up to the lateral, I think lateral is the most important view for any joint. You can see this is the thumb, so this is volar, this is dorsal. Our wire is not in the center, so this is slightly more volarwards than dorsalwards. So all we need is to take our entry point in lateral, 3 or 4 millimeters dorsal, and then we will be bang in the center in line with our radius. Now you see, this was my initial entry point, and I saw that on lateral view this was more volar. That means the K-wire was more facing the palmar direction. All I did was take the same wire, and I have gone 3 or 4 millimeter dorsal, and I have checked it after checking it in AP. So AP was looking good. Now I have moved it 3 to 4 millimeter dorsal, and let's see how it looks now. So if you look at the AP, it looks pretty good. As before, we never had an issue with AP. Now lateral, we have shifted 3 or 4 millimeter dorsal, and I showed you on the patient. Now if you see, it's so much better. It's lined up nicely with the radius. In order to pass the wire bang on parallel, I just need to lift the wire up maybe 5-10 degrees, and then it should be absolutely fine. So now, once you're happy that your position is good on AP and lateral, now you can use your wire holder and think of passing the wire. So once my wire, I'm happy with the position on AP, I just use the finger to bury the K wire into the bone, and that way you don't lose position while loading the wire onto your wire passer. So just use your finger and just push it a little bit, and this way once you load it on to the wire holder, you will not lose position. Now biggest difficulty for the newcomers is how to correlate between AP and lateral. You will find that when a wire is okay in AP, then you lose position on lateral, and vice versa. So once you are happy that your position is good, just pass the wire a little bit, and in your mind you have to remember this angle that you are forming with the bone. So if you remember the radius, you have in your mind, imagine the radius in your head, and this way you will be having a better orientation. So I am passing the wire on AP, and let's look at the position. So now looking at the position on AP, it looks reasonable to me. Now the key is to remember your position on AP and then pass this wire in lateral. So I'll show you what you need to do. So all you need to do is to take the hand in lateral and remember your position on AP and try to line it with radius. So you don't change the position on AP. Let's see how it looks. X-ray. Now if you look at the fracture side, the fracture is looking reduced. Our trajectory of our K wire is more dorsal. So I just need to remember my position on AP and lift my hand up and K wire more dorsal so that the wire will go a bit palmarwards. And if you see the position of the hand, I have deliberately kept this hyperflex. All it does is it tightens the external or extensor structures including periosteum, and it helps in reducing our fracture. So my wire was going slightly that way, so I'm just going to angle it slightly more volar to change the position. So now you can see I am better lined up with the radius, and the wire is absolutely parallel to the radius. I'm just going to proceed till I hit the other cortex. So I'm just going to keep going, and I will pass it till I feel the second cortex of the radius is gone. So it's going. Now I just felt the giveaway of the second cortex. Now let's check AP and lateral. So now if you look at the AP, we just took one attempt and we have gone through the second cortex and looks pretty good on AP. On lateral, our wire is on the center. I would have loved it to be slightly more volar, but it is going through the bone and I have good purchase. So because it's a skeletally immature child, you don't want to damage the physis too many times. So on this occasion I'm going to accept it, and looks pretty good. So now it's just a matter of cutting the wire and then checking stability and putting him in the plaster. So you get a lot of specialist wire bending device, but I find this, the jig for the locking screw extremely useful. So I just put it and use it to bend the wire. So that is what I use. We are going to use just a cutter to cut it. So okay, just hold it. That's it. So we're just going to check the stability, and I don't put more than one wire. One wire is more than enough because I'm going to put him in a molded cast. So whenever you are putting KY in a child and when there is a risk of displacement, I always take a small continuous radiation to check the stability of my wire. So just take a continuous shoot for a few seconds. It looks pretty good.